next speaker is Dr. Stephanie McClure. She is director of the Amarillo Alzheimer's Academy and the division chief of geriatrics in the School of Medicine at the Texas Tech University Health Science Center at Amarillo. Dr. McClure's clinical activities focus on geriatrics. She is the co-PI for a Donald W. Reynolds Foundation grant and is the director of the new Geriatric Education Center at Texas Tech University Health Science Center at Amarillo. She is here to enlighten us on a boomer topic in which she is an authority: evidence-based osteoporosis prevention, controversies, and best practices.
Well, I was asked today to discuss osteoporosis and specifically on prevention. So we'll not talk about treatment per se, other than perhaps talking about secondary prevention, but we'll focus on controversies and best practices. If we try to discuss treatment, we'll probably be here all week. So what I would like to do today is help you to be able to recognize the importance of prevention of osteoporosis. In addition, understand the evaluation towards prevention, and to be familiar with the non-pharmaceutical and the pharmaceutical management towards prevention. Now, the FDA has set certain criteria as exactly what is treatment and what is prevention. So treatment is the actual the documentation of fracture risk reduction with osteoporosis, and prevention here we'll be talking about preservation of bone mass without osteoporosis. I picked a quote from Benjamin Franklin that an ounce of prevention is worth a pound of cure, and it certainly that is the case with osteoporosis, which many of you are fully aware. I just wanted to show you here what the diagnosis of osteoporosis is based on bone density studies. And here osteoporosis is described as a bone mineral density representing a T-score of minus 2.5, and we'll talk more about that. So what are the controversies? When I was asked to present this topic, I kind of developed a list and was thinking about, well, we're talking about the baby boomers. So what am I dealing with in my practice? What do I see out in the community as the controversies and challenges? Well, I think the first thing is understanding osteopenia. Many of us use the word osteopenia like it is a disease. And this is what's controversial about that, is that osteopenia is actually not a disease, if you ask people in certain circles. The term was actually coined in the 1990s by the World Health Organization, and it quickly became adopted by medical providers, utilizing the T-score as the ultimate guiding light. So anyone that had a T-score of minus 1 to minus 2.5, they were deemed osteopenic, and what do? We automatically put them on medication. And then you'll hear later that maybe that was not a good idea. I took some thoughts from Vivian Goldschmidt from her website, Save Our Bones, and she indicates that osteopenia is not a disease. It's similar to what we see with prediabetes. That prediabetes really isn't a disease, it's a condition. Now, would you put someone with so-called prediabetes on insulin? And that's the way that, that we probably should be looking at osteopenia, is that, that it's not something that we treat as a disease. Now, looking back 25 years ago, there was only women specialists that were even treating women for osteoporosis. So there were very few women across the nation that were being addressed regarding this. And then in the 1990s, when the bisphosphonates became very popular, we were putting everyone with osteopenia on bisphosphonates, and it was down if you didn't. You know, you weren't following the standard of care if you was not putting anyone on bisphosphonates. But now you're damned if you do put someone on a bisphosphonate who only has osteopenia. So now the pendulum has swung, and it continues to swing, and now it's out the door, because now we're trying to turn back the hands of time. Because now we're back to osteopenia and trying to decide what to do with it. And that's why it's a big controversy. Because if you look at the data from the NORA study, which is the National Osteoporosis Risk Assessment Study, it was determined that almost 50% of undiagnosed postmenopausal women do have a low bone mass. So they may not necessarily have osteoporosis, which is the minus 2.5, but they certainly fell in this area, the shaded area that's considered to be osteopenia. So the majority of the folks that were in this area in this NORA study actually had fractures without the diagnosis of osteoporosis. So what are the issues that we are seeing? We're seeing that prevention is not being advised or addressed in our clinics. Osteoporosis is not being screened. And if someone is screened positive, are the appropriate pharmacologic interventions being pursued, if at all? And if they are pursued, what are the adverse effects that we need to be cognizant of? In addition, if we're going to put them on medication, the question is, well, how long do we leave them on medication? And at what age should medication not be initiated? And medication adherence is not that great, at least when the bisphosphonates first came on the market, when it was a daily application of the medicine. So it's important to address osteoporosis because, as you're aware, when a woman is going through menopause, there is a rapid drop of bone mass. And it's also a silent disease until there actually is a fracture that occurs. And this provides a significant personal and family burden, as well as economic issues. And that is because there is an increased risk in mortality and morbidity. No longer is a fracture in an older adult similar to that when we were younger. So as a child, you may have gotten a fracture and you were in a cast or what have you, and then you were up and back to your activities of daily living, in a few weeks. Now, as an older adult, it doesn't work quite that way. In fact, only 40% of people actually regain their pre-fracture independence level. And during that first year of fracture, there's actually a 20% risk of mortality. Now, we don't talk about those type of things when we're younger with fractures. So as you can see, osteoporosis and fragility fractures are pretty serious. This graph just depicts what I had mentioned about the bone mass and about the rapid drop in the bone mass during menopause, which is delineated around 50 years of age. It also shows where we develop the peak bone mass, which is in our late 20s or early 30s. This red line shows examples of like women who did not develop their bone mass as expected. For example, if a woman is a marathon runner and she has amenorrhea in her 20s or 30s, she may not develop her full peak of bone. Therefore, as you can see, she does not have much reserve to lose when she starts losing bone at menopause. So as you have heard earlier, there are 44 million people that are over the age of 50 or over the age of 50, and 10 million already have osteoporosis. And almost 34 million have low bone mass without the diagnosis of osteoporosis. So once we reach the age of 50, if you're women in the audience, if you look to your left and right, and if you half of us will have a fragility fracture within our lifetime. And for the men here in the audience, if you're over the age of 50, 25% will have a fragility fracture within his lifetime. Another reason why this is extremely important is the fact that we all know about heart disease, stroke, and breast cancer, how important that is, and how frequent the incidence is of those particular diseases. But if you took all three of these combined, it still does not equal the number of osteoporotic fractures that occur annually within the United States. And you've already heard that the osteoporotic fractures are associated with significant morbidity and mortality. So screening. The population that should be tested include women who are age 65 and older, as well as men over the age of 70, regardless of whether or not they have any clinical risk factors. If the woman or man are younger than those ages, then they should be screened if they have clinical risk factors such as low body weight or are on high-risk medications. Women who are going through menopause should also be screened, particularly if she has other clinical risk factors. Any adult who sustained a bone fracture at age 50 or older should also be screened. Adults with medical conditions or taking medications that are associated with low bone mass should be screened. We're all familiar with perhaps anticonvulsants causing bone loss, and certainly everyone in this room is familiar with glucocorticoids or steroids causing bone loss. But I'm going to mention several other medications that are actually much more common in our population that people utilize from day to day. Anyone that's being considered for drug therapy, of course, should be screened. And anyone that's already being treated for osteoporosis or for osteopenia, for that matter, should also be screened. We don't have internet access, so I'm not able to go to this website. So with that in mind, I did make copies of what I wanted to present today, which is FRAX. And this is, has become the standard of care of determining, particularly in women who may be osteopenic, on whether or not if you should treat her with medication intervention. I hope that everyone can read this from the back of the room. But this FRAX, anyone can get this online, and the hyperlink or the URL was in the previous slide, and it's in your handout. But if you go to the calculation tool, this will actually pull up a variety of countries, including, well, it includes the continents, including North America. And then you have the option of going to the United States. And if the person is white or black, Hispanic, or Asian, you're able to pull up specifics for those populations. But you can enter the patient's age, as well as the date of birth, the gender, the weight you will plug in. You put it in by kilograms, and there's a conversion calculator here that you would include the pounds, and it'll convert to kilograms. Same thing with the height. The height is supposed to be in centimeters, and you can plug that in here. Just plug in inches, and it converts to centimeters. It'll do that automatically for you. And you will indicate whether or not if the person has any of these risk factors, which include a previous fracture, if the parent has had a history of a fractured hip, does the patient have, do they currently smoke? Are they on steroids? Do they have rheumatoid arthritis? Do they have secondary osteoporosis? Alcohol ingestion of 3 or more units a day. And you will also plug in what the T-score for the femoral neck. Okay, this is just showing where I had mentioned that you can pull up the country and then the specific population. Okay, here I've went on and plugged those numbers in, and I put a T-score in of -2.5. Which is diagnostic of osteoporosis, so it's right there on the edge of being osteoporotic and osteopenic. And I said that this person is 80 years old, born in 1930, the weight 61 kilograms, the centimeters is 165, or in other words, 65 inches or 5'5". And I said that this person has no other risk factors. So if we had an 80-year-old with a T-score of -2.5, do we treat her? And the calculations revealed that the 10-year probability of a fracture for her for any major osteoporotic fracture is 18%. To treat her, that percentage should be 20 or greater. So she's right there on the borderline. But if you look at the hip fracture, she actually qualifies for treatment, being that her 10-year probability of fracture is 6%, and the threshold for treatment is at 3%. So you can see that this lady, this result is doubled. So let's take a similar scenario of someone that's 80 years old, female, but her T-score is minus 1.5, so she's osteopenic. Do we commit an 80-year-old with a T-score of minus 1.5, which is the best score without otherwise being, say, normal? Okay. So what I did was try to figure out what the T-score was that she would be committed to treatment, and it actually turned out to be minus 1.5. It revealed that her hip fracture risk was 3.1%. So in other words, if I had an 80-year-old woman who was osteopenic with a T-score of 1.5, then she would be committed for treatment, even though she has no other risk factors. So, that sounds all fine and good. However, there are certain issues with FRAX that are not taken in consideration, as you probably already have determined that from the presentation. The FRAX does not apply to anyone who has been previously treated with medication, and so there's no validated data for persons like that who are currently on medication or who were previously on medications. Individual variables such as frailty and any recent decline in bone mass are not considered when you do your FRAX calculation. And in addition, risk factors for fracture, such as vitamin D deficiency or falls, because we know when a person has one fall that they're at increased risk of another fall, or those implicated medications other than glucocorticoids, those things are not considered in the calculation. The FRAX, however, does provide recommendations, as I had mentioned, that if a person has osteopenia, that it does provide guidance that treatment should be carried out if the hip fracture risk is greater than 3 or more percent, or if the 10-year probability for any other major osteoporotic-related fracture is 20% or greater. Having said all that, though, with this presentation being evidence-based, would you believe there's no prospective studies that have confirmed that using this data actually reduce fracture? So if we're going to treat a person with osteopenia with the risk factors, there's not any data to show that we are actually reducing her fracture risk or his fracture risk. Also, the FRAX does not take in consideration of the spine bone mineral density. And that's important as well because the woman or man can have thoracic fractures, fragility fractures, and not have any involvement at all of the hip. So no osteoporosis in the hip. So this does not even take that in consideration. And even with the spine fragility fractures, there's a high risk of morbidity and mortality with that as well. So let's talk about DEXA. DEXA is the most common screening tool that we are using at the current time. And the specialists regarding women's health had found out a long time ago that it's really technician dependent as far as the actual procedure, because it can really change the T-score. So if the hips are not positioned correctly, or if the spine is not positioned correctly, even with the small difference, that it can significantly affect the T-score in a large way. Also, it's important as clinicians that when we schedule DEXAs, that it's best to have that person have a follow-up DEXA at the same facility with the same machine, because there is variability between the machines, even if it's from the same manufacturer. So if you're going to compare T-scores, it has to be with the same machine. And the original DEXA studies did not include women of color. So it was difficult to determine what do you do with DEXA scores in blacks or with Asian women. Exercise and bone mineral density. Most studies do not detect a difference between effects of endurance training as well as strength training on the spine. And I thought that was quite curious. But there is a good point regarding exercise, being that hip fracture is significantly reduced with exercise. In fact, there's a reduction in fracture by 50% in the hip with exercise. And that's expected that it's multifactorial because exercise affects muscle strength as well as bone and joint flexibility and balance. Now I would like to just shift gears here and talk about calcium, because I would be willing to bet the majority of us here in the room probably think we know all we need to know about calcium, right? Well, that's what the controversy is all about. How many people have understood that the best calcium intake is 1,500 milligrams a day? Well, if you look at the literature, it's not that data is not fully substantiated. There's not any evidence-based documentation. In fact, what the data says is that women age 50 should consume at least 1,200 milligrams of elemental calcium, and somehow they got extrapolated to 1,500 milligrams as being reasonable. But again, it's not fact-based. And I have here that the bones don't care if the calcium came from food. If you're a physician and you trained back when I did, nutrition wasn't a major course in medical school. We weren't taught about metabolism, calcium, and so forth. And when I had completed medical school and talking to my patients about calcium intake, it was my understanding that we're looking at the calcium supplementation when we're calculating how much calcium a day a person is taking. And actually what we should be doing is looking at not only what the patient is receiving through supplement, but what they're also receiving as diet. And that is all part of the 1,200 milligrams. So the 1,200 milligrams is not specific towards the supplementation. You got to take all of the calcium intake into consideration. So the bones don't care if the calcium came from food. And something else interesting to note is that really advising patients to take high calcium has fallen out of favor, especially if the vitamin D level is satisfactory. The total amount of calcium that is generally needed is up to 800 milligrams to 1,000 milligrams per deciliter. So it's unlikely that a person would need a calcium supplement greater than 600 milligrams if the vitamin D level is satisfactory. Also, something that was interesting is that although we push calcium when we're younger, which is advisable, advising kids to drink their milk and dairy products, as an adult, the calcium intake is not related to the bone loss that we see. So it's important for bone gain, but whether or not if a woman or a man loses bone it does not have any relationship to the calcium intake. And actually, it seems that more and more that we know and study vitamin D, that vitamin D seems to be the major player in all of this. So if you take calcium plus vitamin D, we know that there is an improvement of the hip density. However, there's no reduction in the hip fracture. In fact, if we do increase the calcium intake, there may actually be a risk of kidney stones. So let's talk a little bit more about vitamin D because it is getting a lot of play now. There's a lot of research that's going on in the field of vitamin D. And vitamin D deficiency is considered to be levels less than 20. However, in the older adult, I also call 20 to 30 instead of insufficient. I consider that to be deficient as well. So the ideal levels are 30 to 100. Excuse me, the normal is 30 to 100, but the ideal is 40 to 60. There's a number of studies out there that advise that it's important that the vitamin D level be at least 30. And I was going to show a few of those. One is this randomized crossover study, which revealed that if the vitamin D level is 20, that the calcium absorption is inefficient, and being that it's 65% lower if that vitamin D level is 20. In addition, if you look at the Women's Health Initiative, which was an observational study, a study that a lot of information has been extrapolated over the years. They looked at women that participated in that initiative and found that women had a 71% higher risk of hip fracture if the vitamin D level was less than 19. Hence, again, why we're looking at 20. Here's yet another study that if a woman takes 700 to 800 units a day, that generally will correlate with a vitamin D level of 36 to 40. Which would reduce her hip fracture by over 20%, as well as non-vertebral fracture. It did not show that with lower levels of vitamin D. One more study looking at nursing home patients, again, looking at a variety of doses from 200 units to 800 international units, and it was determined that only the 800 units a day actually reduced the incidence of falls, and that those folks who were on 800 units had an average vitamin D level of 30 nanograms per milliliter. So what happens when the vitamin D is low? We know that there's bone loss and fractures. However, it's due to a number of mechanisms which are cascade, which includes that there's an increase in parathyroid secretion, which causes bone demineralization or decreased bone mineralization, and that causes an increased bone turnover. In addition, with low vitamin D, there's an increased risk of falls, and that's actually due, in addition to the bony structure, it's related to neurologic and muscle function. So who are at risk for vitamin D deficiency? Those with advanced age, and it's thought that the possible mechanism is from the reduced vitamin D, skin activation, as well as decreased GI absorption of the calcium in vitamin D. Dark skin, so people of color, there's an impaired vitamin D activation due to the melanin. So someone with dark skin would actually need to be out in the sun much longer than someone with fair skin. Obesity, which I thought was interesting, and that is thought to be related to the fact that although the person may be taking so-called adequate vitamin D, but the vitamin D is not being utilized efficiently, that it's being sequestered or stored in fat, because as you know, vitamin D is fat soluble. And being that it is fat soluble, it can accumulate and become toxic. However, there are no studies to look at what is the safe long-term dose of vitamin D. In other words, if we're advising our patients to take 800 units of vitamin D and they've been on it for 5 years, we don't know if that's safe or not, or if they've been on it for 10 years. But what we do know is that folks who are taking 5,000 international units a day do not go into toxicity. In fact, the only known cases of vitamin D toxicity were those folks who were taking 40,000 units per day. And so that's a long way from what we prescribe in practice. And also the LD50 in man is unknown. So there's a couple of forms of vitamin D supplements. There's the vitamin D2 form as well as the vitamin D3. If I have a patient who has a vitamin D level, say that's 15, then I generally will prescribe like 50,000 international units once a week for 4 weeks, and then 50,000 units once a month for 5 months. And then I'll check a vitamin D level after the total of 6 months treatment. And it's the D2 formulation that is by prescription. So I promised you that we'd go over some medications that can cause low bone mass loss and an increased risk of fractures. PPIs, they're in abundance now because they're over the counter. And it's important to recognize and to discuss with your patient that if they are going to take calcium, then they probably should take the calcium citrate form because the calcium carbonate is not absorbed well because of the decreased acid. The selective serotonin reuptake inhibitors, or otherwise known as SSRIs, there seemed to be some relationship there with increased fracture, as well as the glitazones that we use for diabetes. And I have the references there if you'd like to look at those in detail. So if we look at pharmacologic intervention, it is divided into two classifications. They're either anti-resorptive, which inhibits osteoclast activity, or they are anabolic, in which they stimulate osteoblastic activity. And being that we're only going to discuss prevention today, I'm going to limit the discussion to this line here. The alendronate, abendronate, risedronate, and zoledronate all are the bisphosphonates, which are approved for prevention as well as treatment. Raloxifene, which is approved, again, for prevention and treatment, and estrogen for prevention. So bisphosphonates. Bisphosphonates are the best as far as improving bone mineral density when you compare it with estrogen as well as raloxifene. And it is a very potent drug, being that it will bind to the mineralized surface of the bone, and it's taken up by the osteoclast, where the osteoclast will actually die off. And so when that happens, is that you no longer have the bone resorption or the bone turnover. Because as you recall with bone, even as adults, there's building up of bone and there's degradation of bone. And so it's a cycle. And when you utilize bisphosphonates, the data, when you look at the package inserts of all of the bisphosphonates, they reduce fracture risk over 1 to 3 years by a significant amount. And here's the data here for the spine as well as the hip. And I just simply combined all of the bisphosphonates into those figures. But there are certain issues regarding bisphosphonates. And if you watch the news, if you're on the internet and type in bisphosphonates, probably the first thing you see was an attorney's advertisement regarding bisphosphonates. And that's because of BRONJ, or otherwise known as bisphosphonate-related osteonecrosis of the jaw. This is a photograph from Dr. Mark's textbook regarding ONJ. He's pretty much he's a dental provider and a dental specialist, and he's pretty much dedicated his life to ONJ, I believe. But this is a photograph of what? What is this here? This is a mouth, of course. Say that loudly.
Mandibular tori.
Oh, she's a dentist, so she's getting technical here. Mandibular tori, yes. Or this is a torus. That's a torus. Together, tori. But those are bony prominences in the mandible, and it's often, if you run your tongue in the bottom of your mouth, you may feel these. If you have, or if you contemplated dentures, you know, some people can't wear dentures because of these. But these present a problem because they're covered with only a thin amount of mucosa, and also the periosteum is very thin. If that skin, I'm calling it skin, if that mucosa or skin is knocked off, then in a normal person, you hope that that will heal, but someone on bisphosphonates, that may very well not heal. And also keep in mind that the mouth is a very dirty place, and there's lots of germs there, and that will set this person up for infection. Here's a photograph from one of my dental partners in Amarillo, from Dr. Kirk Curry. He's an endodontist. And this is the patient that was in his practice. This white area here, this is necrosis of the bone. So this is someone that had maybe some minor trauma, perhaps brushing their teeth, and they stepped off, and maybe they were a little more aggressive than what they should have been. But for whatever reason, nicked skin off, or the mucosa, and this bony area became necrotic. Here's some other photographs that I just retrieved off the web, but these can be small and localized, otherwise asymptomatic, or they might be large, painful, and disfiguring. And this all here is necrotic bone, so dead bone. And that's what's so scary about this, and that's one of the issues that we have in the Panhandle, is trying to convince our dentists to do dental procedures on patients who are on bisphosphonates. And I'm not sure if that's an issue here in San Antonio, in this region, but it certainly has been a struggle up in West Texas. So you may ask yourself, well, why the jaws? Why does this occur in the jaws? Because we know that the bisphosphonates are being deposited in the hip. We know it's being deposited in the spine, so why aren't we seeing osteonecrosis of those areas? And it's thought that it's probably due to the rapid turnover that's usually expected in the mandible. In fact, here in the superior ridge of the mandible at the alveolar ridge, the bone turnover rate usually is 10 times the rate of the tibia. So you can imagine that if you give a bisphosphonate and the bone is suppressed and there's injury to that area, that it's not going to heal. Having said that, it's important to recognize also that this is a very rare event. In fact, only 1 out of 100,000 have this problem. And these are the known risk factors for BRONJ. If there's dental alveolar trauma, and I want to clarify that simple dental extraction of a tooth does not put a person at risk for ONJ. If they have a dirty mouth, gingivitis, that will put the person at risk. The duration of bisphosphonate exposure. If a person's been on bisphosphonates for over 3 years, that's seen to be much more risk than, say, at 1 year. The type of bisphosphonate, if it's given IV, as opposed to oral, IV is more potent. It gets into the bone and it stays cumulatively for a much longer time. That puts the person at risk. And of course, steroid use as well. So what are the signs and symptoms? If a person has an irregular mucosal ulceration that's revealing exposed bone in the mandible or the maxilla, generally there is pain or swelling in the affected jaw. There may be tooth mobility, depending on where the osteonecrosis is. There will be infection with or without pus. And the person generally will describe it as like a heavy sensation in the jaw. So again, anyone who's on an oral bisphosphonate and they're contemplating elective dental surgery, that is not contraindicated. You may ask, well, should we not use like bone turnovers to decide the markers to determine when would be a good time to do dental surgery, since we know that bisphosphonates will cause bone suppression. And although Dr. Marks has done a lot of work in this area about bone markers, in fact, he advocates checking the C telepeptide level, or the studies, however, are not very supportive that's a good idea, because people who have some people who have osteonecrosis actually have normal CTX levels. So there's still a lot of study that needs to be done. And again, the risk for ONJ seems to occur if the person's been on the bisphosphonates more than 3 years, and then again the steroids. About 3 years ago, there was in the media there was talk about atrial fibrillation, which is an irregular heart rate generated from the atrium of the heart, and it seemed to be associated with IV zoledronate as well as alendronate, which is Fosamax. But the FDA reported in 2008, they made a statement saying that there was no clear association. When they looked at the data in detail, it did not appear that there was any more atrial fibrillation in the bisphosphonate group compared to the placebo group. And then most recently, we've been hearing about atypical femoral fractures. And usually when a person has a fragility fracture, say if they fall, that particular fracture is in the hip, high in the hip. But what's being reported as being atypical are the subtrochanteric femoral fractures, in which the thigh bone, the femur, is actually fractured. And this occurs even with low energy trauma. So just a simple fall, and these people are presenting with fractures. But again, the FDA reviewed this data and found no clear connection. However, it's kind of hard to convince me that when you see in the literature of reports like this. This was in the New England Journal of Medicine in 2008 by Leonard and al. This radiograph shows a femoral shaft fracture in an 83-year-old who was on alendronate for 9 years. And this one also shows a fracture of that's similar in a 77-year-old woman with a 5-year history of alendronate use. And what it makes this unique in its appearance, and which is kind of strange, is that the fracture deformity is described as the beak neck in the proximal end here, like a beak neck. And also there's cortical thickening of the femoral shaft. So having discussed that, if you look at this particular study, though, you may ask, well, what was the vitamin D level? What was the parathyroid hormone level? What did the DEXA reveal? And unfortunately, for some reason, those things weren't checked. And we all know, if the vitamin D level is low, that can cause fractures. Really, the data is inconclusive. We can't truly say that this is secondary to alendronate. And those factors, we all know those other factors have to be ruled out. So how long should we continue the bisphosphonates? There's not any real good studies to guide us on this. In fact, fracture benefit evidence from continuing bisphosphonates for beyond 5 years is lacking. And we really need more data as to when would be a good holiday. The current thinking is that if a woman has been on bisphosphonates for 3 to 5 years, we probably can give her a holiday, particularly if she's at low risk for fracture. However, if she's at high risk, moderate to high risk, then we probably need to continue the bisphosphonates until we can get more data.
And how long a holiday would you make it?
The question is, how long would we make a holiday, say we do stop that? Again, the data is not real clear, except there are some studies looking at alendronate, that even after 1 year, the bone mineral density seemed to remain the same. So it's kind of unlike what we see with menopause. With that rapid reduction of estrogen, there's a rapid loss of bone. That does not seem to be what happens with bisphosphonates when it stopped, that the bone mass continues to be high or stable. I want to make that clear, that when you give bisphosphonate treatment, and say you did a T-score, you checked the T-score 2 years later, and say the bone mineral density is the same, that's not a treatment failure. What we want to see is to make sure that the bone mineral density did not decrease. So if it increased, that's wonderful, but if it remains the same, that's great. Now shifting gears to hormone replacement therapy or estrogen therapy. Estrogen is FDA approved for prevention, however, it's not recommended. And you may recall from the Women's Health Initiative that it is no longer recommended because of that particular study. In that study, there was an increased risk of heart attack, stroke. However, if you looked at that data in more detail, you would have noticed that it was the women of advanced age who were recently put on estrogen that were having those problems. And we all know that for menopause, it's probably most appropriate to put a woman on estrogen when she's going through menopause rather than several years or decades down the road. Also keep in mind with the Women's Health Initiative study, they use conjugated estrogen, which is Premarin, which is the pregnant mare urine. Not related to human estrogen. So there's not any studies looking at estradiol, which is what our bodies make. Looking at SERMs, which are estrogen agonists, antagonists. Raloxifene is the prototype for this category. We use it to prevent invasive breast cancer. It is the only SERM that's approved for prevention and treatment of osteoporosis. And it's only utilized for reduction of fracture in the spine. And actually it's pretty decent. It reduces fracture by 30 to 50%. The drawbacks on this is that it's similar to estrogen, being that it can cause DVTs, but it's opposite of estrogen, being that it can cause hot flashes, nausea, and leg cramps. It also affects lipid metabolism just like estrogen. However, unlike estrogen, it does not have any cardiovascular effects, so there's not an increased risk of heart disease. Moving on to calcitonin. Calcitonin is not for prevention, and as I said, I was going to focus on prevention, so I'm not going to go into this. It's in your handout if you would like to look at that. Teriparatide, or Forteo, also is on the market, but it too is not FDA approved for prevention. It's utilized for treatment. The newest kid on the block is denosumab, which is a rank ligand inhibitor. It was approved by the FDA in May. Again, is not used for prevention, so I won't go into that one, but it's there for your perusal. So treatment should be based on fracture risk, and the therapy is more clinically effective and more cost-effective in patients who have a moderate to high risk of fracture. However, estrogen is the only one that shows that there's a reduced fracture risk if there's osteopenia. And bisphosphonate therapy, we probably shouldn't be using it in patients who only have osteopenia, but it is appropriate to use it if the person has osteopenia with risk factors. A little bit about green tea polyphenols. One of my partners at Texas Tech, Dr. Leslie Shin, she's a basic scientist in Lubbock at the Laura Bush Institute for Women's Health. She received the NIH grant funding to look at green tea and Tai Chi. And her study utilized over 1,000 potential subjects in which they did recruit 171 with a mean age of approximately 58. And the study intervention included whether or not if they got the green tea or got placebo every day, and whether or not if these people received Tai Chi 1 hour for 3 times a week or no Tai Chi. And the compliance rate for the study agents, so the ones that were on the green tea, was 89% compliance, and there was an 83% compliance with the Tai Chi classes. What the results are revealed was definitely a positive effect on bone remodeling. In fact, if a woman takes green tea, it did seem to help with bone formation as the bone alkaline phosphatase was increased at 4 weeks. And with Tai Chi, there was a significant increase in the bone alkaline phosphatase at 12 weeks. And the same trend of Tai Chi was also present at 24 weeks. If you looked after 24 weeks and compared it with placebo, the folks that were on green tea or utilizing Tai Chi or a combination of both did reveal that there was an improvement in muscle strength as well. So how old is too old for prevention? As one is never too young to start prevention, the same goes for one is never too old to take action to slow osteoporosis down. So it's never too late to improve lifestyle habits, and it's never too late to actually begin medication. As you can see with bisphosphonates, you can get an effect within 1 year. So unless that the life expectancy, if you expect that person to die within 1 year, then certainly bisphosphonates would not be an answer, or other therapies. Adherence to therapy also is or was one of the controversies. It is important to realize that in order to reduce the fracture risk by 25%, the person or the patient needs to be compliant with the medication over 80% of the time during the 2-year period. However, in common practice, adherence does seem to become inadequate within 3 months. However, nowadays, the compliance does seem to be better now that we have access to once-a-week therapy, as well as once a month and once a year therapies. So in summary, the major recommendations towards prevention include counseling regarding the risk of osteoporosis and fracture. Again, putting this in perspective, when our dental providers are advising patients not to go on bisphosphonates, it's important that we counsel that the risk of morbidity and mortality is very high, and that the risk of BRONJ is very low. We need to check for secondary causes. We need to advise of adequate amounts of calcium and vitamin D. We need to encourage weight-bearing exercise and strengthening, and simple walking will be sufficient for weight-bearing. And of course, advising regarding tobacco cessation and avoiding excessive alcohol. Again, women age 65 and older and men 70 and older should be screened for their bone mineral density. Those younger, if they have risk, should be screened. We would recommend bone mineral density for those who've had sustained a fracture, because you need to determine the degree of severity of the osteoporosis. And if you initiate treatment, again, it's important to follow to see how your treatment is going. Because after 2 years, of course, if they're worsening, then you need to regroup. Other recommendations, you need to initiate the therapy, of course, if there are signs of osteoporosis. So if the T-score is minus 2.5, as I demonstrated with the FRAX. If they're osteopenic with risk factors, then those people need to be treated. The current medications for prevention, I have those here again for you. If you're going to refer patients for bone mineral density testing with DEXA, it's important that they have a good quality assurance program, that they're certified. If you're putting patients on medications for osteopenia, then it's important to check the DEXA in 2 years, or if they're on steroids, it probably would be a good idea to check in 1 year to see how your therapy is going. So I'm going to stop here and entertain any questions. This is the second largest canyon in the United States. Anyone know? Right, Paladura Canyon, so in right in the West Texas, near Amarillo. And so I'm in the sun getting my vitamin D activation.
One of the things that I've been getting phone calls on from dentists in the community are just the kinds of things that you've been saying. You've had a hard time convincing dentists in Amarillo that they need to go ahead and do treatment, and that basic oral surgery in terms of extraction is okay. What are you telling them with regard to actually doing dental implants?
Yes, Dr. Curry has basically advised that if the treatment is urgent and they need to pursue that, then he'll go right ahead and do that. Otherwise, it's probably a good idea. It's common practice to stop the bisphosphonate for a while, but again, the bisphosphonate stays in the system for years. And so, but in general, it probably would be a good idea to stop the bisphosphonate and then pursue the surgery.
Okay. One of the other thoughts about that too is that they need to do it as untraumatically as possible. So it's getting an expert who really does a lot of them.
Exactly.
Yeah.
So if someone needs invasive surgery, such as an implant, it's important that that patient goes to someone that is very proficient in these type of cases. And for Amarillo, I mentioned about an endodontist. Actually, our oral surgeons won't touch. We have 5 oral surgeons in our community who will not even touch a single patient with bisphosphonates. So either our dentists, there are some dentists that will go ahead and do whatever needs to be done because, it's unethical to leave patients in pain. They need to be treated. Otherwise, Dr. Curry, as an endodontist, has been doing the surgeries on patients.
Do you ever recommend coral calcium? And is there a buildup in your veins or arteries of the calcium if you're taking excess calcium?
As far as calcium, any of the calcium products on the market are excellent. And to answer the question about the buildup of calcium, no. As far as the arteries and veins, there's no evidence that occurs. If there's abnormalities within regarding the phosphorus, then there is a possibility of calcinosis occurring, but that's not usually localized to veins and arteries. That may be tendons and other areas, other organs that might be involved. Yes.
Hi. I'm wondering if you could speak to 2 things. One is this month an article came out in the British Medical Journal about calcium supplements and increased risk of heart attack. And it's calcium without vitamin D, but nonetheless, it was concerning to me, and I'm wondering if you had a chance to see that. It was a meta-analysis of like 15 studies.
I see.
And then the second thing, if you could talk a little bit about, there are studies that show that countries where people eat more plant-based diets, either they're vegetarian or the meat is more like a condiment in their diet, that they tend to have much lower osteoporosis than our society. And so if you could talk to those 2 things.
Okay. To address the first question regarding calcium intake and association with heart disease, I have not read that particular article, but I think I've had at least one patient that has mentioned about being on a calcium channel blocker as why they wouldn't that increase their risk of having a heart attack if they took calcium supplementation. And regarding that study, I have not looked at it in detail, but again, I think we're finding out a lot about calcium that we didn't know before. We used to push calcium, and I think that might be one of the areas that there would need to be further exploration as to its true relationship. Because theoretically, you're also, back when we were using calcium channel blockers, especially the dihydropyridines, like nifedipine, especially the immediate release, those were precipitating stroke because of the rapid reduction in blood pressure. And that was the dipyrhydrazine classification. So I think, those calcium channel blockers, they've been on the market for what, 30 years now? And I think now we're finding out more that maybe they're not such a good idea. Because we had already found out back, I think, maybe 20 years ago, 15 years ago, that we shouldn't give calcium channel blockers with someone with an acute MI, that we should utilize beta blockade. I see. No, I haven't seen that. And your second question was regarding folks in other countries who are primarily vegetarians, that there's a little evidence of osteoporosis in those populations. And I don't exactly know other than I know with example like with the green tea, this green tea study, when you look at the literature regarding green tea, whether or not if it's junk science or not, green tea seems to help with a lot of ailments. And that may very well be the case with vegetarians, that there may just be some something like a phenol or what have you that might be protective.
The theory is that we eat a lot of animal protein, and this type of protein takes out calcium from our bodies, or causes us to raise more calcium from our bones, versus vegetables.
Okay.
So, do you know much about
Okay.
that?
Okay. The response that she had was that it seems that animal protein seems to leach or not efficiently to excrete more protein as opposed to a vegetarian diet. I really don't know much about that area. Is there anyone else here that might know? What kind of China study? Uh-huh. I see. Okay. All right, thank you. Well, thank you very much for inviting me.
Buenas noches, iniciamos con noticias de última hora. Les saluda Brenda Jiménez.
Y Jorge Núñez. Pues ¿estará usted de acuerdo que nuestra cultura nos enseña a respetar a las personas de la tercera edad? Pero no siempre es fácil cuidarlos durante la etapa de la vejez.
Por esa razón, líderes en el campo médico se reunieron bajo el mismo techo el día de hoy y Anabel Monge nos explica más.
Así es, Jorge Brenda. Según los expertos, el cuidado para las personas de la tercera edad puede convertirse aún más difícil si ellos viven con algún problema físico o quizá alguna enfermedad. Para la mayoría de las culturas, los abuelos son preciados miembros de la familia, pero a la vez todos sabemos que el envejecer no siempre es fácil. Esta etapa puede llegar a ser más frustrante cuando la persona de la tercera edad vive con problemas físicos o demencia.
Comunicando con una persona o diciéndole que necesita ayuda o que quiere comer, por ejemplo, puede ser algo bien difícil para una persona que tiene la enfermedad.
Los expertos indican que los problemas físicos y el dolor crónico disminuyen las capacidades y aumentan el estrés y la ansiedad, no solo para el paciente, sino también para la persona que le está prestando cuidado médico o emocional.
Y es muy importante que las personas que los cuidan, que se educan sobre la enfermedad y qué pueden hacer.
Con la meta de educar a la comunidad y en especial a los integrantes del campo médico, hoy viernes en San Antonio se realizó un foro informativo donde mediante discusiones detalladas se habló sobre las diferentes enfermedades que afectan a las personas de la tercera edad y cómo sobrellevarlas.
Es muy importante educarnos, saber qué podemos hacer, saber que conectamos con la Asociación de Alzheimer's, en conectarnos con tipos, con grupos de apoyo.
Y bueno, aunque este foro informativo se realizó aquí en el centro de la ciudad de San Antonio, la sesión contó con la presencia de varios expertos de a través de toda la nación. Anabel Monge, Noticias 41.